Today, my role was actually an exciting one. I presented new guidelines for the management of malignant pleural mesothelioma. This was the first time that we've had guidelines for this disease at this conference, so it was an actual honor to present those. The guidelines were challenging to create because this is a very rare disease. There are only about 2,000 cases of mesothelioma per year in the United States, and that's 100-fold less common than a disease like lung cancer. This is a disease, of course, that's most likely going to be caused by asbestos exposure, although there can be other inciting factors such as patients who've had radiation therapy for Hodgkin's disease. They can be at risk for getting mesothelioma as well. Most patients with mesothelioma will present with pleural effusion, and so they'll have subacute onset of shortness of breath. And those patients will usually have that fluid drained, but it's quite difficult to make the diagnosis based on that. You often need a more involved surgical procedure to get more tissue to analyze. And so with regards to making the diagnosis, we had several guidelines as far as the initial workup that included imaging studies such as CAT scans. We can do PET scans, and the SUV can correspond with the aggressiveness of the disease. It can also be used to identify occult metastatic disease. To better make a diagnosis, we usually use some kind of surgical procedure such as VATS, where you can actually obtain tissue samples. There are different subtypes of mesothelioma, and this can include the epithelioid subtype, which can be difficult to distinguish from adenocarcinoma. Fortunately, now we have several different immunohistochemical stains to help guide us with that. The epithelioid type tends to have a better prognosis and respond more frequently to chemotherapy. At the other end of the spectrum, there's a sarcomatoid type. Those patients with that disease have a more aggressive type of tumor and respond infrequently to chemotherapy. And then there's also a mixed or biphasic type, which has elements of both in the pathology sample. So patients, once they've been diagnosed with mesothelioma, we generally recommend that they get management from a multidisciplinary team. Because this is a rare disease, it often requires people who have had some expertise with managing this disease to help determine the best course of treatment for them. We have different modalities of therapy for these patients. The first that could be considered for patients who have earlier stage disease, these would be patients with stage 1 through 3 disease, would be surgery. And there are basically two types of surgery that can be performed. One is a pleurectomy decortication, which is just removal of the lining of the lung. This is a less morbid procedure, but it's also more of a debulking procedure, generally does leave some disease behind. The more aggressive surgery is called an extrapleural pneumonectomy. This involves removal not just of the lining of the lung, but also the lung itself, the diaphragm on that side, and a portion of the pericardium. It's a much more aggressive surgery, but in highly selected patients and in patients who are, in the hands of experienced surgeons, that type of surgery can be done safely with a reasonable rate of mortality. So once the patient has had surgery, then we generally have advocated for some type of adjuvant therapy because these patients are extremely high risk of having relapsed disease. The surgery, even a more aggressive type, can leave disease behind. You can have microscopic disease seeding the pleura. So we've advocated for radiation to help decrease the risk of local recurrence. These patients are also at risk for systemic relapse, and so we generally like to give some chemotherapy as well. We've also discussed the recommendations as far as radiation therapy goes. And radiation really has two main roles in managing this disease. One is for use as adjuvant treatment after surgery. As I mentioned, in patients who've had a pneumonectomy and had the lung removed, then radiation can be given to that hemithorax to decrease the risk of local relapse. Radiation can also be used as a palliative treatment. So if patients have tumor that's invading into the chest wall, they can receive a course of radiation to that area to help relieve pain. Or they can have radiation to instrument sites because, for example, in patients who've had a VATS procedure, the mesothelioma can track along the incision sites, and so the radiation can improve that risk. radiation does carry certain risks because patients can get pneumonitis from the radiation exposure. So for patients even who've had an extrapleural pneumonectomy, the contralateral lung can get radiation exposure, and there have been reports of fatal pneumonitis after patients have had intensity modulated radiation therapy to the surgical side. So that has to be done quite carefully. With regards to chemotherapy, we provided some guidelines as far as the optimal chemotherapy regimens. The one that's been best studied is the combination of pemetrexed and cisplatin. There are phase 3 data showing that the combination of pemetrexed and cisplatin improved response and survival when compared to treatment with cisplatin alone. And that's really become the standard first-line regimen and is the one that now has FDA approval for that indication. There are some patients certainly who aren't fit enough to tolerate treatment with cisplatin, and there are reasonable phase 2 data to show that the combination of pemetrexed with carboplatin has a similar level of activity and reasonable survival rates, so that would be another combination that could be used as well. The original chemotherapy regimen that showed some activity in this disease is gemcitabine with cisplatin, and there are several phase 2 trials that have shown activity with that combination. And if pemetrexed for some reason is not available, or if you wanted to use a different regimen, that would be one possibility. Lastly, there has been a phase 3 trial looking at the comparing chemotherapy regimens, MVP, mitomycin, vinblastine, and cisplatin, or treatment with vinorelbine to best supportive care. And that trial was actually done around the time that the data for pemetrexed emerged, so the trial was stopped early. But they did show that in the subgroup analysis, there seemed to be some slight advantage to treatment with vinorelbine, so that would be yet another option. The role of chemotherapy in the second-line setting in patients who progress after first-line therapy is really less well studied because the data with first-line therapy have really just emerged. So if patients didn't have pemetrexed as first-line therapy, there are actually phase 3 data to show that treatment with pemetrexed in a second-line setting can help with regards to response and progression-free survival. Although in that trial there was no difference in overall survival, probably because the patients in the best supportive care arm ended up getting pemetrexed eventually as well. Vinorelbine would be another reasonable second-line option. I mentioned the data in the phase 3 setting in the first-line study, and there's also been a phase 2 second-line trial with vinorelbine showing some activity. And lastly, gemcitabine would be a reasonable second-line option. So with those guidelines in mind, I think that we've made the first step as trying to identify the best treatment plan for these patients, and it'll be interesting to see how these guidelines evolve over time.